We all are at the verge, after a long period of lockdown, at the verge of opening and our practices. So it is a high time that we should look into it, and we should, as the condition, as the pandemic of the COVID is a very serious issue. So how to start, how to move forward in a stepwise way, we will be going in various slides now. So I have no financial interest. How to practice in COVID era, precautions to be taken. This is the transmission electron micrograph of SARS-CoV-2 virus particles, as could be seen. And I am Dr. Purendra Bhasin, Ratan Jyoti Netralaya. Ophthalmic practice, as we all know, comes in a high risk zone because we have to go close to the patient when we have to practice, and conjunctivitis could be presenting or associated feature, although it is yet to be proved. And because of the insufficient distancing between the patient and examiner during various points, and multiple points are there for the investigations, like vision, tension, refraction, slit lamp examination, fundus examination, long waiting period, and all is required in ophthalmic practice, unlike in general medicine or other practices. Our long stay in clinics are there, where we have small examination rooms. There are dark rooms with absent or restricted natural ventilation, and closed vent or central air conditioning without the HEPA filtration is there in various clinics. So this has been collected from how they started their practice in Hong Kong. And this is, so now it's high time to start to think to return to our normal, near normal process. Now we should consider the process of reopening our practices. We have to start opening zone wise. Green zone, these people will begin their practice early, then yellow zone, and last will be the red zone, which will be asked to start their practices. Those areas which are in red zone. We should remember that SARS-CoV-2 virus has not yet gone. So therefore, we have to go stepwise. Seeing emergency patients with care or no patient at all, this is the way those who have been seeing the emergencies patients during this period of last 1 month, so they have an idea, they have some made some protocols of their, and they have attuned their staff also to work like that, as compared to those practices who have not yet opened their clinic in last 1 month. For them, it will be very difficult and challenging. We have to practice with care, caution, protection of ourselves, our staff, and our family members as well. Using experiences of our knowledge, wisdom, scientific information, we have to develop protocols to work safely. This is from Hong Kong experience, which has been published in Graphe Arc Ophthalmology in 2020. There are various measures have to be adopted. The three-level hierarchy of control measures should be taken into consideration. We have to sensitize our administration. We have to sensitize our staff for the environmental control and for the personal control as well at the same time. So for the in coming to the administrative control, we have to plan the patient scheduling, triage, develop the triage area. Triage means the area before the patient is taken inside for the examination. We have to develop an area, a zone wherein the patient has to take a rest, and further history taking has to be done. Like declaration questionnaire has to be passed by the team, has to screen in the triage area the patient and their attendants. This form, this questionnaire has been distributed by already Ophthalmic Society, which is good enough, very nice. I have made a one which I will be sharing with you. Avoid doing less necessary procedures when the patient comes to you in our early time. We have to develop, as far as possible, paperless workup. We have to maintain social distancing. We have to have infection control training in our hospital with our staff. And for that, we can conduct mock drills, and some staff has to be deputed to monitor all these things. Like scheduling the appointment is very important. We have to postpone all the routine outpatient consultations till there is a lockdown in your city. Only emergency or urgent patients should be seen. This then how to the ophthalmologists themselves are have to use their own judgment and individual medical condition of the patient to whether to call that patient to the clinic in these emergency days or not. And as far as possible, for any trivial complaints or burning irritation like that, you have to give them teleconsultation and ask them if when the lockdown opens, when the things become normal, then you can come and show us further. In this, if there is a serious problem where the patient is having pain or so, like as you can see in this, the child has a preseptal cellulitis, we can ask the patient to send their pics, and then we can suggest them the treatment. If required, we can give a hospitalization, suggest hospitalization. Insist on appointments and discourage walk-in as much as possible. Postpone all elective surgeries and procedures till there is a lockdown. That is very important. And I have been discussing it with my colleagues at other places. They have all stopped doing elective procedures. And till the lockdown is there, but we should be prepared whenever, we never know when the lockdown will open, but we have to gear up ourselves and we should prepare ourselves to start doing elective surgeries as and when the lockdown opens. We should say no to patients coming from hotspot areas. So all these things, our patient who, the staff who is giving the appointment or the doctor who is giving the appointment should know which are the hotspot areas. Coming to the triage area, we allow one attendant per patient inside the premises. Avoid entering children in the premises if they are not a patient themselves. Develop a patient screening desk. Staff protected with the best available protected methods, personal protective equipment, as you can see here. And all persons, patient, attendant, visitor, and staff coming to hospital shall pass the thermal screening based on the history and non-contact thermometer if it is available. We all know it is not freely available now, but soon things will be better. In the triage area, all patients and their attendants have to sign a COVID-19 self-declaration form or consent, as some people say, at the time of registration process. This self-declaration form includes history of symptoms, travel, occupation, contact, and clustering. As you can see here, we have developed this self-declaration form, which has a name, age, gender, the address, email address, mobile number, reason to visit the hospital, how they have come, vehicle number, driver name, so that because all these forms we are sending to the administration in Gwalior. And if the patient is coming from a hot spot area, which we are not aware of, they can find out and they can scrutinize this form and they can go back and find out if the patient is having any problem with which has developed in due course of time. And we have to ask them, do you or any of your family members have had a fever, cough, cold in last 2 weeks, or have traveled to foreign or infected areas like Markaz, Delhi, Maharashtra, Indore, Bhopal, etc., or any area in your vicinity, in your state in last few months? If yes, please give detail of place visited. If there is any loss of smell and taste, because this is the earliest symptom which we have added to it, if the patient or attendant has any loss of smell or taste, any member in the family has the above symptoms, if yes or no. If the answer is yes, then you have to give full details below. During the lockdown, in the wake of current corona season, I have come to the hospital by myself for ophthalmic consultation. This declaration the patient has to give. And another thing is that if I have an asymptomatic carrier, if I am an asymptomatic carrier or an undiagnosed patient for COVID-19, I suspect it may endanger doctors or hospital staff. It is my responsibility to take appropriate precaution and to follow the protocols prescribed if in future, if they develop, anybody of this all chain develop corona. I also know that I may get an infection from the hospital or from a doctor, and I will take every precaution to prevent this from happening. But I will not at all hold doctor and hospital staff accountable if such infection occurs to me or my accompanying person. I assure that the information given by me above is absolutely true, because most of these patients, they hide their history, they hide their complaints, and nothing has been hidden. And I know that in case of concealing the above mentioned facts, an administrative action can be taken against me. This information has been sought from me for the purpose of preventing the COVID-19 epidemic. This is the detailed form which we are taking from our all patients who are visiting us in both of our hospital. So there itself we can segregate patients who are having fever or such kind of symptoms which we have mentioned. And if they are positive, if they are giving the history, then then we have to ask them not to come to us. Or if the problem is the complaint is simple, then they can be referred to a place where there is a ICU facility, or they can be referred to the COVID-19 hospital which government have developed. If the symptoms are trivial, from distance, you can prescribe them medicine and they can go from outside. If they say no, then if they don't have any such complaint or they are not having suspicion of corona, then we can take them inside and examine it as we will be doing it in now in our talk. Or if they have if they have some symptoms and they have a red eye, then we have to take them to the red eye clinic, where everything has to be done with PPE and full protection, and change everything, and the patient has to be seen and sent immediately outside. And that has to be done in a segregated area. No crowding at registration, optical and pharmacy counters. As you can see, this is our reception area. Keep a gap of 1 chair between two people. This has been indigenously done to restrict patient to sit in between, and people in OPD waiting areas. Ask patient to maintain social distancing in designated squares. Am I audible? Everything is clear? Hello?
Yes, you're audible.
Yeah. So because there was no this thing, so we have to develop a red eye clinic. This I am taking it first because this is very important. And if the patient has conjunctivitis or red eye with the patient, for the patient, then we have to see them separately in a separate designated area away from crowd by a designated doctor with full PPE support. In general, in OPD areas, plan appointments for only 50% or less patients and attendance combined of the clinic center's total seating capacity. Say if your capacity to see is 20 patients in 1 hour in the hospital, or 30 patients in an hour. So now you have to work for entering only 10 patients or 15 patients in 1 hour inside the hospital premises. That has to be taken care by the administration, by the staff, and they have to restrict patients entering inside the hospital premises. Maintain only one entry and exit point. We should mask is to be provided for every staff, patient, attendant. This has to be ensured at the doorstep. The moment they come to us, they have to be asked to wear mask. If they have not worn it, then we have to provide them. We have to arrange the mask to be kept outside. They have to be provided, and it is to be strictly worn by all when they are inside the premises. Before entering, we sanitize or ask the patient to wash their hand with soap, and this has the sanitization of the hand should be frequently done inside the premises. Patients should avoid carrying old files and records as much as possible. We have to formulate new protocols for examination in order to have a less necessary procedures to be done on the patient. Avoid contact procedures as much as possible. Routine aerosol generating procedures in ophthalmic practices should be suspended. Most commonly, which is said, is NCT, if we are doing in all cases. So we have to restrict in doing only in suspect glaucoma patients, and immediately after it has to be cleaned and the area has to be sanitized. and in intubation and extubation in general anesthesia, that has to be avoided in the early days. No routine autorefractometer and refraction for each patient. So what I mean to say here is that we have to go specific to the complaints of the patient, those who are coming and visiting us. We cannot ask the patient to go for each and every examination like complete test we do in our routine practice earlier. Initially, we have to restrict ourselves and go as per the complaint of the patient. We discourage contact lens use and contact lens trial during this period, and it has to be discontinued. All non-essential, non-critical examination should be avoided, and patient explain need for more elaborate testing in future as feasible. And this will decrease the time period for which the patient is inside in our hospital premises. That also has to be decreased. Our aim should be to decrease the time period and at the same time the visits of the patient. We have to work paperless. Most of us are doing EMR workup. Avoid touching patients' old prescriptions and reports, and we may ask patient to click photographs and send you in advance or over there. And reducing instances of hand-to-hand transfer, handing over of bills, prescriptions should be avoided. We can send them by email all the bills and prescriptions. Avoid cash transactions. Plastic folders should be discontinued to avoid multiple touching. We have to maintain social distancing as long as the patient and amongst our staff. This picture came to in the yesterday's Patrika newspaper in our region, where the tigers are following the social distancing. There is a scale also under that which they have used, and the tigers are following a social distancing as if they are aware of this long before we have come to know. And in infection control training, reinforce both patients and care workers the importance of hand hygiene, respiratory hygiene, and cough etiquette. We have to, all these things are very, very important. Proper steps of hand hygiene, donning and doffing of personal protection equipments should be explained, should be taught to our staff and everybody. Even the gloves, how to remove, where to remove them, and how to send it to the biomedical waste, and how it has to be processed. That all things has to be shared with everybody. Although we know most of us are NABH accredited, so we are mostly all of us are aware of it, but still everything should be repeatedly informed. Staff coming from hotspot areas should not be allowed to come, should be asked to stay there back, because they are a vulnerable source for COVID. We should display visual alerts at the entrance and inside at the strategic areas, in waiting areas, elevators, etc. If we have PA system, public announcement system, then we should keep on announcing frequently all the instructions repeatedly in between when the patient is inside the hospital premises. And this is important for our staff also, because anything, it's a chain. When we are in a single clinic, in a or in a multiple practicing doctors, these things are different. And people, if in a chain, anybody gets distracted, it doesn't follow this, the whole of the staff and all of the hospital, everything has to bear the consequences if it happens, if the hospital is or anybody develops COVID in the hospital or the staff develops. So that will be a major setback to the hospital. And above all, monitoring to be initiated and reinforced by the quality team. Coming to the infection control, clean the seat and table with sodium hypochlorite solution every 2 hourly. Any material discarded by the patient also may be disinfected with hypochlorite. How the hypochlorite solution is prepared, that is given in this. All the instruments, etc., should be cleaned, and at the end of the day, we should wash and sanitize the hospital premises completely. Coming to the general OPD related instructions, what we have to follow: use new prescription for all patients. Avoid taking the file from our record. That will avoid the travel of the COVID. Reduce average time per patient spent with a gap of 3 to 4 minutes or 5 minutes for sanitization of chair, table, doctor's hand, slit lamp, etc. before you see next patient. While dispensing medicines, prefer no-touch techniques with the patient. After every use, clean all instruments or objects which have come in contact with the patient face or the body with 70% alcohol, like 90D lens, gonio lens, retinoscope, chin rest of autorefractometer, perimeter, OCT, fundus fluorescent angiography, slit amp, trial frames, AT probe, immersion cup or Prager immersion shell, etc., etc. Everything has to be cleaned after each examination. Coming to the slit lamp examination, which is the most important thing, examination in our practice, basic examination in our practice. Perform slit lamp examination in a patient you feel is necessary. Use slit lamp barrier shields, breath shields for added protection. Use gloves while you contact patient to examine. Inform patients that they will not speak during the slit lamp examination. Refrain attendants talking in between. Avoid touching the lids. Use buds to lift the lids and see the patient cornea and the hidden parts of the eye. Sanitize everything used with 70% alcohol solution after every examination. Doctors and optometrists have to wear slit lamp barriers, like slit lamp shields or breath shields. As you can see here, these are the, this will protect against virus droplets. Slit lamp shield should be cleaned after every patient. We have, as you can see here, this is the protective shield, or this is fixed. I think all of us have already fixed it now by now. If those who have not done it, they should do it. It is very simple. Even the file cover can be cut and placed over here, or X-ray film can be used. And I'm wearing a slit lamp the shield over the face, and while doing the indirect examination. This shield, we have made it at our place, and it's very simple. These sheets are freely available in the market, and a thread can be stringed to it. There are 3 holes, and thread can be passed to it, and now this will protect. This can be fixed to our forehead. Although occurs some these excessive sweating and fogging in between, but this is very comfortable, and it protects us completely from the micro droplets which can harm us. Another thing is the use of multi-dose eye drops when we are using in our amongst our patient when they are sitting in the OPD for the dilatation of the patient. We should avoid touching eyelashes or ocular surface with the tip of the eye drop bottle. This is very common thing which our staff does. Disinfect examiner's hands immediately after touching the patient's face. Everything is contaminated unless cleaned in your presence. So clean your desk, doorknob, computer, workstation, yourself or in your presence, and elevators, switches of elevators, etc., and the switchboards has to be cleaned. Dilate for fundus evaluation whenever necessary. Not all patients need to be dilated, or maybe we can use fundus camera, a non-mediatic fundus camera for this, and we can see the central fundus, and if there is nothing wrong, nothing serious, then we can send the patient early, or call next appointment for dilating if required. Use only one pen in hospital and leave this pen in the hospital. Use phone in between. Avoid using phone in between seeing your patients or in between doing other work. Use phone after every 2 hours with proper care. What I do is I keep the phone and take a break from the OPD or from other work, and then with the separate things or separate gloves, I pick up my phone and check the messages or the phone calls. Have water with care from water bottle. That is also important, and we should always take water in between our practice. Avoid watches, no rings, no bangles, no dangling earrings for the female staff. Hair should be tied and cover your hair with cap. Shift to scrubs, full sleeves if available. Keep your palms together as we do it in our operation during our surgery, so as to avoid touching face or other things. Keep door opens when you are seeing the patient. This will decrease the virus load and increase the exchange of air inside your chamber. if you have opened the air conditioning system. Avoid lifts, closed spaces, don't touch lift buttons, get them cleaned frequently. Doctors should give longer follow-up for post-ops who don't need any intervention. Coming to, lastly, when we do emergency surgery or when we are going to start our surgery, we have to get a routine screening of the chest X-ray before each surgery. If COVID-19 test is available in our city, then we should get it done before taking a patient for the surgery. Try to avoid general anesthesia unless mandatory. Prefer topical over local anesthesia. Stop positive ventilation in theater during procedure or for at least 20 minutes after the patient has left the theater. No two patients should be handled together. There should be a minimum 20 minutes time out between each surgery. So change all instruments and everything of the trolley. And for the phaco, you can change the handpiece also during the phaco, while doing a patient phaco for other patient, and sterilize it again, or maybe you can change the sleeve and tip. Minimum possible staff in OT while the procedure is being done and outside also. And all should use PPE kit. PPE means not the kit which is like a dangri. We can use HIV kit, gown kind of a thing. That is because we are used to of doing such thing. We practiced of doing with this. And I use double gloves. We use goggles and long foot covers so that any spillover from fluid which is there from the patient's eye should not be connected with our body part. Patient should change mask before taking in the OT. The mask which the patient is wearing when they have come in the hospital premises should be changed when they are taken for the surgery inside the OR. To conclude, I know I have just touched few things which have come to my mind and which are many of them are also available in over the net, and we have also gone through it. Just with this presentation, I wanted to sensitize you all. If you have any queries or questions, you can ask to us. All the panelists are experienced and very much aware of all these things, how to practice, how to start practice. Important thing is, before concluding, that we should consider all patients and attendants that they are infected with COVID in view of asymptomatic carriers, and they might be harboring in the incubation period of this virus, which can be of 14 days or maybe 21 days or 39 days in extreme cases. Resources should be prioritized and optimized. We should avoid unnecessary exposure of healthcare personnel to potentially infected patients and vice versa. This is very, very important because then it will be devastating for the organization. Follow social distancing, use specific PPEs for safety by each and every staff of the hospital. We should assess, procure, and stock new required things before you start. We should have adequate stock with us so that if you start, you should not feel shortage of things with us when you have started once. Avoid doing things in haste. Once again, I reiterate that those who are already practicing the emergency patients, those who have already started seeing the patient in emergencies, they have had made some specific protocols out of this. Well, but things will be different for them and things will be different for those who have not practiced during this period at all. So for them, please be sure of that this is not a simple thing. We don't do anything in haste. We take all precautions. Mentally prepare yourself. Do mock drills before you start seeing the patient. And with this, we cannot direct the winds, but we can adjust the sails. This is what I would like to say here. And with this, I thank you for your patient hearing. All these two pictures of flowers have been taken by me during this lockdown period at my terrace in last few days. Thank you all. Thank you for your patient hearing.